So I'll be talking on the management of ocular hypertension. Ocular hypertension is defined as intraocular pressure more than 21 millimeters of mercury with Goldman applanation tonometry in one or both eyes on two or more occasions with open angles, no evidence of structural or functional optic nerve head damage, and no other ocular or systemic causes for raised intraocular pressure. So the question here is, do you want to treat all cases of ocular hypertension? Let us look at the evidence from the major landmark trial, Ocular Hypertension Treatment Study. According to the OSTS, 20% reduction in intraocular pressure reduced the incidence of POAG by more than 50%. However, the treatment of all ocular hypertensive individuals is neither medically indicated nor economically justified because of the high prevalence of the disease, low conversion rate to POAG, cost of the treatment, and the side effects of medication. So they have suggested the use of a risk stratification to identify the patients who are at risk, high risk of developing glaucoma, and these patients may benefit from an closer follow-up and early treatment. From the ocular hypertension treatment study, they have found the baseline factors associated with increased risk of POAG. They include increasing age, central corneal thickness, thin cornea, high CD ratio, high pattern standard deviation, and high baseline intraocular pressure. So based on these risk factors, they have classified the population into three groups: the low risk category, medium risk category, and the high risk category. In the low risk group, there is not much significant difference in the mean risk of development of POAG and also the confidence interval between the medication and the observation group. So the risk for progression to POAG is less than 6% in this group, and the number needed to treat is 1:98. That is, you have to treat 98 patients with ocular hypertension to prevent one person going in for open angle glaucoma. In the high risk group, where the risk is more than 30%, they found a significant difference in the mean risk for developing POAG and also the confidence interval between the medication group and the observation group. Here the number needed to treat is 1:7. So the low risk group definitely not require any treatment, they need observation, and the high risk group need definitely treatment. However, in the medium risk group, where the risk is between 6 to 13%, you can decide whether you want to start treatment or observe based on other risk factors. From the pooled data from ODDS and EGPS, a predictive model to estimate the risk of conversion from ocular hypertension to glaucoma has been developed, and in this, they have given some points to baseline predictors. And when the sum of these points is 0 to 6, the risk estimated 5-year risk of POAG is less than 4%, when it is 7 to 8, 10%, 9 to 10, 15%, and 11 to 12, 20%, and more than 12, more than 33% risk of development POAG. So while deciding the management, you have to consider this, and along with this, systemic or ocular comorbidities and family history of glaucoma. So let us look at some case scenarios. This is a case of a 64-year-old male with no systemic comorbidities. Anterior segment and the fundus examinations were within normal limits. Intraocular pressure, mean IOP was 23 millimeters of mercury in the right eye and 24 in the left eye, and the central corneal thickness was normal. Disc were normal, fields were normal. So when you consider the baseline predictors, the sum of the points comes as 6. That means the risk is less than 4%. That is a low risk patient. And here we can observe with an annual follow-up. In case 2, everything is same as in case 1, except the mean IOP has increased to 31 and 33 millimeters of mercury. So when you consider the sum of the points, it comes as 9. That means the estimated risk is 15%. Only the intraocular pressure has raised, everything else is same. So this is a high risk category, and you have to start treatment with a 6-monthly follow-up. and you can choose whichever drug you want. I prefer to use PG analog when the IOP is more than 30%, and laser trabeculoplasty is also an option according to the reports from the recent LIGHT trial. Case 3, it's the same as in case 1, except the central corneal thickness, which has reduced to 530 from 560. So here the sum of the points becomes 7. That means the risk is moderate. So since there is no other risk factors, and I decided to observe with a 6-month follow-up in this patient. Case 4 is same as case 3, but the pressure has increased to 28 and 29 millimeters of mercury. Here there is high intraocular pressure and also thin cornea, multiple risk factors. And the sum of the points here came as 11, and the estimated 5-year risk is 20%. So this is again a high risk group, and start treatment with a 6-monthly follow-up. Again, the treatment is either anti-glaucoma medications or laser trabeculoplasty. So to conclude, ocular hypertension with multiple risk factors or presence of high risk factors need treatment. Ocular hypertension with less risk factors or presence of low risk factors needs frequent follow-ups to detect the earliest sign of progression to initiate treatment. You have to remember that every patient with ocular hypertension need lifelong regular follow-up regardless of treatment. Thank you.